All right, guys, we're going to get started again. Hopefully you got some coffee and some snacks. All right. How you guys doing? Hanging in there? Having fun? All right, good. That was mostly energetic, not much. It's about what I would expect for 10 o'clock in the morning. All right. Our next speaker is Dr. Brian Feeley. So much to say about Brian. So Dr. Feeley and I worked together in a combined clinic that we started not that long ago, so we worked together a lot. He is the UCSF Chief of Sports Medicine and the Executive Vice Chair for Orthopaedics. Dr. Feeley's been with UCSF since 2008. You've been there that long?
Yeah, I'm unhireable anywhere.
Yeah, nobody wants him anymore. And he earned his medical degree at Stanford, which is too bad, his orthopedic surgery residency at UCLA, which is worse, and then his fellowship at HSS in New York, which is pretty cool. Dr. Feeley is celebrated for his research and teaching efforts at UCSF and has won numerous prestigious awards for his work over the years. Dr. Feeley is a team physician for St. Ignatius High School, who's playing in the, what is it?
NorCal
Championship tonight.
Division II AA, Part C, Level B.
Yeah, what he said. They're going to kick a lot of field goals. And he's an avid sports fan, and he runs one of our awesome podcasts through UCSF with doctors Drew Lansdowne and Nirav Pandya, who you guys will see while you're here today, called 6 to 8 Weeks. You guys can catch that out. They've got some great episodes. They have some really bad episodes with PTs too, so don't listen to those ones. But fun facts. I've been giving you guys all fun facts. So fun fact about Brian, he thinks his holiday decor is better than mine for Christmas decorations. But really, he's just a dinosaur fiend and decorates his whole house with dinosaurs. So we just refer to him as the Ross of UCSF. Ooh. If you don't understand that reference, you're younger, and you should go watch it on Netflix. Friends, that's what it's called. All right, so without further ado, Dr. Brian Feeley here to talk to you guys about shoulders.
All right. That was awkward. All right. Till 11:40? 11:20. Okay. 11:20? Okay, thank you. So this is my favorite talk that I give all year because I really like talking about shoulders. I spend a lot of time trying to think about how I can streamline getting through clinic. And I think with shoulders in particular, so much you can get from just asking a few questions, doing a very directed physical exam. And despite the fact that patients will often say they have a myriad of different problems around the shoulder, it really boils down to relatively few examples, which makes it sort of easy to get through clinic efficiently. I know for me, when patients come in, they will say, I've got a shoulder problem. And for many of you, it may be the fifth thing they bring up after they've already brought up all their other problems. And it's like on the way out, they're like, oh, by the way, I can't lift my arm. What do I do? So I'm going to try to get through how you get through this rationally so it doesn't break your soul every time somebody does this at the end of a visit. I also am focusing not on athletic injuries. Mainly because that is a whole different talk. This is more focused on things that people will see kind of on a day-to-day basis that athletes do get, but it's much less common. So these are my disclosures. I have research support from a variety of different places. I have an extra comma. I do editorial work for 2 different journals. I have stocks in companies that don't pay me money because they're not very good. So we're going to cover shoulder anatomy. I put that in your notes. Hopefully you remember shoulder anatomy. And then when we do the hands-on stuff, we'll go over like kind of surface anatomy a little bit more. We'll talk about physical exam and how I do it quickly and efficiently afterwards. So we're going to go over primarily chronic shoulder problems. We'll get caught up in some of the literature that's come out in the last 5 years or so. And I won't really talk about zebras, but you always want to think about the weird things that can cross the shoulder, namely cervical spine problems, brachial neuritis, and things like scapular bursitis, which see you more than you realize you see that. I like to think about this no different than how I thought about med school. So med school, we were often taught to do a differential and then come up with your most likely problem. And we're really good about doing this if it's abdominal pain or chest pain, but then we forget about it for the musculoskeletal exam. So when I teach this for medical students, residents, and fellows, I like to think it's no different than trying to figure out what's wrong with a belly. It's a shoulder, so the list is a lot shorter, thankfully. So in a nutshell, we're going to talk about what shoulder problems you'll see, how you get to the bottom of these efficiently, and what treatment and information are your patients actually going to ask you. I'm going to skip this for time, but the most common diagnoses that we see in clinic, and my clinic is all things shoulder and elbow, 45% of the time somebody comes in with a rotator cuff problem, 15% of the time shoulder arthritis, 15% of the time frozen shoulder, which is pretty darn common, and 15% of the time is a biceps problem. Occasionally we'll have shoulder instability, occasionally fractures, sometimes just bruises and strains, and those are really reassuring when patients come in. They're like, am I okay? Usually by the time they've made the appointment and they come back, you're like, yeah, you're actually okay. A lot of the time this overlaps with cervical spine problems, and it's sometimes a challenge to figure out, is this shoulder, is this spine, or is it both? It's both. The way I like to think about this is for all these diagnoses, where their pain is and what their chief complaint is are going to be a little bit different. And we're going to kind of go over this again and again. But for rotator cuff tears, they tend to have lateral sided pain. So pain more on the outside of their shoulder, tends to be pain at night, pain with overhead activities. And a lot of times they'll say like, well, I'm fine doing my normal day-to-day things, but getting something out of a shelf and bringing something down. I had a patient, she's in her mid-70s. She's like, I'm doing great with physical therapy. It's like, okay, can you get something off a shelf? She's like, absolutely. I can grab something and I can bring it down. And the problem with that is that's not very functional for her, except for the fact she says she's happy. So we don't actually need to treat that, but that's a classic rotator cuff problem, is like you're fine doing day-to-day things. It's this overhead with your arm extended problem. For biceps tendonitis, which is really common in all the gym bros that you see, they've had their protein, they took their peptides, then they went to the gym, and then they sat on their phone, so they kind of sit hunched over. They have anterior shoulder pain. It's really only pain with activities, but there's no loss of motion. There's really no loss of function. Shoulder arthritis, the pain tends to be everywhere because it's arthritis. We've all seen arthritis in other joints. We tend to forget it happens in the shoulder. The pain, if anywhere, tends to be a little bit more posteriorly and along the back of the shoulder. And then they have sometimes a loss of motion, but oftentimes it's with rotation. Now, I can say the exact same thing with frozen shoulder, except for it's pain that's in a slightly younger demographic. The patients are usually miserable. They move their appointment up. They show up early because they want to be out of pain. They have loss of motion, but they have normal x-rays. So I like to think of this as I have to get through a lot of patients. I tend to try to see somewhere between 32 and 40 patients in a given day. So I need to get through this quickly. You might only see 20, 25 patients, 15, 20, but the problem is they've run through all their other problems, or they're not there for you for your shoulder, or for their shoulder. If they're there for you, your shoulder, that's awkward. So how can you get through this efficiently? So if there's an acute injury, does it make sense? So if they fell down, they went snowboarding, they fell down, they cannot move their shoulder, they're going to get an x-ray, and you should refer them to an orthopedic surgeon. I asked, so if there's not an acute injury, and most of the time either they say there's an acute injury, but it doesn't make sense. That time I reached into the back seat and grabbed something. That's not an injury. That's just you irritated something that's inflamed. They will pinpoint that as the time they got injured, but that's not really an injury. That's different than I fell off the half pipe, or I was mountain biking and I fell down. I then asked, where does it hurt? With one finger, where does this actually hurt you? Because that'll narrow down the diagnosis a lot. Are you losing range of motion? It's either a yes/no question, and they'll usually show you, and then they'll diagnose their own frozen shoulder right in front of you, and then you're kind of done. And are you losing strength? And for losing strength, I kind of ask that in two ways. Like, are you unable to raise your arm up, or are doing things out in front of you challenging when they weren't challenging before? Because that'll guide you towards, is this a rotator cuff problem? So I like to do this case-based. This is Danny. This is how he trains his patients. This is why Danny has a very small patient population. So this is a 58-year-old male. He says 6 months of shoulder pain, mostly lateral, hurts at night, pain with overhead activity. Doesn't really describe weakness, but when he goes to the gym, he can't lift as well. So I didn't know how to use the Hova app. I kept calling it Hova, and I couldn't download it. So what does this sound like when you hear this? Yeah, it sounds like a rotator cuff problem. So good, rotator cuff tear. All right, so if I go through my questions, was there an acute injury? Not really, it doesn't really describe anything. Where does it hurt? He already told me. Well, it hurts laterally. I'm thinking, okay, rotator cuff problem. Are you losing range of motion? No, he's going to the gym. He still feels fine. So the likelihood of frozen shoulder or a fair amount of arthritis is relatively low. And are you losing strength? Well, sort of. He says it feels different, can't do the things at the gym he wants to do. Now, the tough part about rotator cuff tears is we describe this really poorly, right? So when we designed how to talk about rotator cuff tears, we put a lot of crappy diagnoses and names in there that confuse everybody. And I know this because we wrote a paper, we wrote a review paper on rotator cuff tears, and we sent it to the editors, and the editors were like, what were you all thinking when you named this? None of this makes sense. I was like, well, it wasn't me, but I totally hear you. And she's like, you all need to rethink how you describe rotator cuff tears. And I was like, well, I can't do that, but I can at least talk about the fact that it's really confusing. So I like to think about this as a spectrum of everything that can happen, but not all of this is bad. Okay, so impingement, the way I describe it, is not a physical impingement. It is a word that we use because we used to think it was a physical impingement because there was a bone spur poking on you. That is not true. Okay, the bone spur is in the front of the shoulder. You don't actually impinge on it. That was Dr. Neer's way of operating on everybody that came into Columbia. The way I describe impingement is like it's inflammation. If you're standing on top of your roof and look down, it would be like having leaves on your gutter. The actual structure of your roof is fine. Everything's going to be okay. We just need to get the leaves off. And we can do that with physical therapy. We can do that with an injection. Rarely would you ever want a surgery on your roof to just get the leaves off. And patients seem to sort of understand that, even if they have an apartment. Partial tears are slightly different, but usually okay. And the way I describe that is there might be a few shingles missing, but that's okay because you have layers and layers and layers on top of your roof. And that would be a bursal-sided tear. Or it may be like you have a little crack right up there. The rest of it's fine. Structurally okay, it's not gonna rain on you. It might not look perfect. You might think about it a little bit more on a heavy rainstorm, but you're probably not gonna do anything. You wouldn't wanna tear down the entire roof to fix a tiny crack. It's no big deal, okay? And that seems to work. So when we talk about these, I like to think about impingement, which is what you're gonna see in your kind of like 40 to 60-year-olds, as this inflammation that happens as we keep our rotator cuff strong and our deltoid stays strong and our rotator cuff gets relatively weak, just like the rest of our core muscles. And you get this abnormal motion pattern that if you just send patients to physical therapy and you rebalance that, you get their rotator cuff stronger, they're no longer gonna have symptoms. I tried to look for what's new since I gave this talk last year. There's nothing new. The same data. So what works for this? Physical therapy works well. Hands-on physical therapy as opposed to just sending them to a home exercise program works better. The reason is you can't see what you're doing on your back, but Danny and the other physical therapists can tell you, actually that's not your rotator cuff. You're still squeezing your shoulder blades. Your rotator cuff sits on your shoulder blade, not squeezing your shoulder blades together. So when I watch patients do physical therapy exercises, I'm often like, oh, that's actually doing nothing for your rotator cuff. So having somebody who can tell them that's good, that's not so good is really helpful. Surgical management actually works really, really well, but so does physical therapy. So there's no reason to jump to surgery for this. So my treatment algorithm for patients that I see is if they have mild pain with a little bit of activity, they get a little bit of night pain, I send them to physical therapy and say, you should try this thing. It's called ibuprofen. It's amazing. They get better. 90% of the time they will get better. Sometimes if they have more moderate pain, it's waking them up at night or it's waking their spouse up at night, I'll say PT, anti-inflammatory, sleep is really, really important. So I say, look, if it's really bothering you with sleep, we can do an steroid injection. That's fine, it's safe, you're not gonna die. And then do the physical therapy, get them better. Very rarely do I need with patients with impingement to get an MRI. And surgery for impingement, I do maybe twice a year out of 300 surgeries. So what patients really want to know when you get through this with them is, will you get better? Yes, you will get better. Only 30% will progress over the next 5 years to any sort of from partial thickness tears or inflammation to anything that looks worse on MRI. So this is a normal finding if you get imaging. Do you need surgery? Probably not. It's probably not going to make a difference. There's no benefit to jumping into surgery. Will you damage the shoulder if you use it more? This is the most common question you get, right? Like when a patient hears partial thickness tear, what they're imagining is you've torn half of the piece of paper and it's about to tear all the way. So what I tell patients is your rotator cuff is very robust. It's about a centimeter thick. A partial tear of less than 2 to 3 millimeters is like tearing 2% of your rotator cuff. And you think about it, if I had one thread off my coat that's torn, I can't rip it yet. It's not a big deal. You will not damage it more by doing anything other than getting older. And they're like, oh, great. Oh, wait a second, Chad. So, okay. Unfortunately, Danny keeps working with this patient. Now he says he really can't lift at the gym as well. And he says he got an MRI from a local surgeon. He's up in Arcata. And of course, they're recommending surgery because surgeons like to operate. It's much, much more fun. But he's got this amazing trip coming up. He's going into Canada. He is renting his Winnebago, and he doesn't really want surgery. And the questions we often get are, do I really need surgery when I have a rotator cuff problem? Now, the way I like to think about this is it really, really depends on what your symptoms are, how old you are, what your goals are, and how big of a tear this is. So when we say full thickness tear, this unfortunately is still a whole spectrum of problems. So for a small full thickness tear, there's two problems with it. One is many of them are asymptomatic. So about 70% of them we can see as an incidental finding, but the location is important. So what I tell patients is, it's like, okay, well now you have a hole in your ceiling. It also goes through the roof, but again, it depends on where in the house it is, right? If it's over like that kid's, your 16-year-old's bedroom, you're like, okay, fine, let it rain on them. If it's over your couch, okay, you might want to get that fixed. And that's important because if this tear is right at the leading edge of the rotator cuff where your biceps becomes uncovered, more the mechanical advantage comes through that part. So we may be a little bit more aggressive. As these tears get bigger, sometimes they become a massive tear and there's no way around it. You're going to need to fix it. So that's like the whole roof blew off. It's really hard to live there. Even your 11-year-old who is secretly your favorite, it's not really a secret, they can't sleep, so you're going to fix it. So these massive tears are things that we're going to want to fix, especially acutely. And fixes, again, it's a complicated thing that we should be having that discussion with them because it may be we repair it directly, we do a tendon transfer, sometimes we just say, forget it, we're going to replace your shoulder. But if it's a big, big tear, we should be seeing them. So patients, once they have what I would say is a full thickness rotator cuff tear, they want to know what happens. Oh my God, am I going to die? Also, patients think when they have a full thickness tear, their arm's going to fall off. Like literally, I will say, what do you think happens next? They're like, well, my arm will be on the ground. Sometimes. What happens if you don't fix it? What's the natural history of this? And what happens if you fix it? Am I going to get better? So when do people get symptomatic? So oftentimes you have patients you treated with physical therapy, they go away. Tears, when they get bigger, is when people get symptomatic. So about 50% of people with a full thickness tear over the next 5 years, that tear will get bigger. But the thing is they will usually come back and see you. So I tell patients, look, if you're asymptomatic, if you're happy with how your shoulder is right now, go live life, enjoy. But if it gets worse, I want to see you back because that may be that your tear is progressing. What happens if you don't fix it? So a lot of times the problem is patients feel pretty darn good and they always have a friend that hated their orthopedic surgeon for doing a rotator cuff repair, or they hated the physical therapist that made the tear worse by having them like do gentle exercises. They didn't, but that's what we hear. So when people do become symptomatic and they remain symptomatic, we think that tear has progressed to what we would say is a critical size tear. It's gone from like that tiny, tiny tear to more symptomatic. It gets into that anterior cable, which is the biomechanically important part, and your muscle starts degenerating. That takes anywhere from 1 to 3 years for symptomatic people. But once that happens, that starts to lead to kind of a cascade of progression. So when people have looked at this was a great study done out of the northern half of Japan, where they first MRI'd everybody in a village and found the incidence and found that 2/3 of people had a rotator cuff problem on imaging. There's a study coming out in the next month or so with JAMA Internal Medicine, which I've heard is a good journal, that shows that 90% of people over the age of 65, 70 have rotator cuff problems on imaging in an asymptomatic population of Finnish people. So it might be only if you're in Finland and you have a rotator cuff problem, but this seems like it's a pretty good study. So what they found is the risk factors for progression was you're older, you have some muscle degeneration, fatty infiltration on your MRI, and the tear is bigger. So the way I like to tell patients is when you have small tears, it's not a big deal. But as you get older, well, that's going to have a factor. As the tear gets bigger, it's kind of this self-progressing thing. Your muscle starts to deteriorate. You don't have the same pull. And if you're not healthy, you've got diabetes, you have hypertension, that's all going to make things worse. But we're still talking about kind of like slow over the period of years. So don't panic yet. If you don't get this fixed, about half of patients with no symptoms will become symptomatic over 3 years, but only about 1/3 will have any muscle progression. So overall, this is a very slow progressive problem. So I tell patients, please don't panic when I say, hey, you should get this fixed somehow in the next period of time. I say over the next year, usually, for these degenerative problems, if it's really symptomatic. Don't change your plans. Don't drop out of whatever job you have. Don't retire early. Just keep working, do what you want to do, and find a time where you can dedicate to physical therapy. Now, what about the patients say, I really don't want surgery? Is there any evidence that says I don't need surgery ever? And there's a great study that orthopedic surgeons quote all the time. We call it the MOON study for Multi-Center Orthopedic Outcomes Network. It's also because we haven't published that many other really great studies from this group, but it's basically a group of shoulder nerds who got together and they did a really nice cohort study. And what they did was they took patients that they said, do you want rotator cuff surgery for your full thickness tear? And they're like, I don't want that. That sounds horrible. And they say, great, we're going to enroll you in this study, and we're going to see how you do. And what they found was that it didn't matter how big the tear was. It didn't matter the gender, whether or not they smoked. The only thing that mattered in terms of whether or not they did well was, do you believe physical therapy will work for this? For the people that answered yes and don't want surgery, not surprisingly, over 95% of these patients at 10 years have not had surgery for this and say their shoulder is fine. The other thing that's really important about this study is patients declared themselves in the first 6 to 12 weeks. So I tell patients, like, you're not sure you want surgery, you think physical therapy may work, let's try physical therapy for the next 2 to 3 months. You will know if you're getting better and you're going to stay better and you're happy, or you don't. And that gives us enough time to think about it, gives you a chance to try physical therapy. The worst that happens is you meet a physical therapist, you know that you have a working relationship with them, and if you need surgery, you're going to work with them afterwards anyway. The best that happens is you avoid surgery and you avoid the rehab. Oftentimes patients will ask, well, what about a steroid injection? I've heard they're horrible. I can only have 3. Okay, well, nobody's ever proven that. It's a hard thing to say. Is it how many of you have heard you can only have 3 steroid injections in your life? Right. Well, which body part? Is it 3 per life? Your whole body? Yeah, it's hard to know. So somebody came up with the number 3 and said you can't have more than 3, but we've never, ever, ever proven it. So what I tell patients is this is what we actually know. If you have surgery within a month of having a steroid injection, you have a slightly but statistically significant higher of an infection. You have a higher risk of recurrent tearing, meaning we fix you, it may re-tear if you've had an injection within 3 months. So we want a washout period. So if you want the injection, I'm just not operating on you for 3 months. And if you have lots and lots of injections, it seems to be a little tiny bit worse than a single injection, but we're talking like 7 to 10 in one body part, meaning your shoulder, versus 1 to 2. So that's a big, big difference. So an occasional injection is totally fine. It's totally safe. It doesn't cause your tendon to tear. Life causes your tendon to tear. It might make the quality of your tendon a little bit worse, but also if you think about the multiple injection study, think about the person you injected 7 times. They were a horrible surgical candidate. That's why you were injecting them. They also have the diabetes. They got the problem with the sugars. Their blood pressure is a little bit high. They got a lot of factors working against them, which is why you were managing them differently. So these studies are hard to interpret. This is kind of a nice study that was done. I really like this because it was done during COVID, and it asked 2 questions. What happens if you get it right away? What if you wait? And basically, both groups did the same. So there's no reason to rush patients into surgery. We did a lot of studies like this during COVID or after COVID because you could actually answer these questions like, what happens if you don't get into physical therapy for 8 weeks? Because there was no physical therapy available and they were all on Zoom. It turns out it doesn't really make a difference. So a little bit of delay for rotator cuff problems is totally fine. I'm going to skip this because this is me nerding out about muscle. But what about how patients do when we actually fix the tear? And there's multiple studies that show when you compare patients head to head, when they're younger and higher demand, they will do better, especially in that 5 to 10 year period. This was the most important study. It's now about 5 years old, but basically, Dr. Moosmeyer and his colleagues did this study where they looked at people at 2 years, 5 years, and 10 years, and they'd been randomized to PT alone and physical therapy and surgery. And what they found was both groups did pretty darn well. But when you looked at that 10-year follow-up, you did statistically better if you had a rotator cuff repair. So what I tell patients are, hey, look, what do you want to be doing in 10 years? And if a patient's 82, their answer is usually like dead. If they're 68, they're like, look, I've got this pickleball thing coming up. I'm playing golf. I want to be active. So I said, what does 10 years from now you look like? If it's active, we should think about fixing this sometime in the next year. If it's dead, then let's not fix it. Let's let you enjoy life. So we do know our outcomes of rotator cuff repair. The smaller tears do better. We know that your muscle quality is better. They're less likely to re-injure themselves. The rehab is a little bit easier, and there are better long-term outcomes. So if someone's symptomatic, they don't get better with physical therapy. That's why I say, okay, we tried. Let's just fix your shoulder. So my algorithm is if it's a chronic degenerative problem, and usually I'll have them try physical therapy. Oftentimes they've come in and they've done physical therapy. If the MRI confirms that they have a tear and they're weak on exam, I'll do physical therapy, maybe an injection, and I'll be a little bit more aggressive with surgery because being weak is hard to manage on a day-to-day basis. If they don't have any weakness and it's just pain, I tend to really try to encourage physical therapy and an injection because surgery doesn't always cure pain. Pain is a lot more complicated. So I will only operate on pain if they're really, really adamant. I'll wait till the picture's done. Thank you. Okay, so what patients ask, will I get better? Yes. If you do physical therapy, you will get better, but that tear doesn't heal. Okay, and that's okay. Every time I look, I have a little bit less hair here. I'm surviving, barely. Do you need surgery? You may do better with surgery if you're higher demand and you're going to live a longer time, but you don't necessarily need it right away. Will you damage your shoulder if you use it more? No, you're not going to do more damage. Okay, if you want to know, they did a whole video on this cohort study. I thought this was really good. So if you want to watch that, that's a good way to think about how this study was done. So second case. All right, we're moving off of cuff. I'm happy to answer more questions about cuff afterwards or at lunch. 54-year-old woman presents with 4 months of shoulder pain that occurred after taking her jacket off. She has pain everywhere, sometimes into the elbow. She can't get things off of high shelves. She can't even put her belt on. Your colleague, thank you, Dr. Hadamiya, got an MRI, shows a painful partial thickness cuff tear as well as a labral tear. What is her diagnosis? I heard painful shoulder. Louder. Yeah. Midlife, yeah, I know. She also complains of back pain, her foot hurts, hurts when you get up and lap. Yeah, so this person, when I think about this person is frozen shoulder until proven otherwise. And the way I like to think about frozen shoulder is, when does your reasonable patient come in and is suddenly somewhat unreasonable? Well, only if they have a lot of pain. Rotator cuff problems don't cause a lot of pain. Arthritis is an achy, annoying pain, but it's not a lot of pain. Frozen shoulder is a misery type pain that takes even your reasonable patients and turns them unreasonable. So what I asked for frozen shoulder, was there an acute injury? These are classically the patients that'll give you this injury that makes zero sense. Oh, that time I picked up my phone. Okay, how heavy is your phone? Is it like the 1978 Nokia? They're like, no, it's an iPhone 4. I'm like, okay. Their pain is everywhere. They can't pinpoint it. They say, are you losing range of motion? And that's usually the first question I ask it. They're like, yeah, I can't reach anything. I was like, okay, scratch your back. And like, I can't do it. Or sometimes they'll be like, I'm fine. And like, well, that's 90 degrees. What about the other side? They're like, I'm all the way up. I'm like, that's frozen shoulder. But they're not really losing strength. The other thing I ask every patient I think that has frozen shoulder is moving slow better than moving quickly? Like if I throw a ball at you, can you catch it? I always kind of want to have a ball and throw it at them and just see what happens, but I feel like that would be a patient relations thing. But they will say moving slow is a lot better than moving fast. And that's because frozen shoulder has a lot of inflammation. It would be like having a jammed finger and just kind of stretching it versus like moving quickly. It's going to hurt. So I like to think of frozen shoulder as having basically a shoulder that's been jammed and is really inflamed. If you look at it, like 10 patients with frozen shoulder and you ask them to take like a shirt or jacket off or move, you should be able to diagnose it within about 6 seconds, because as soon as they do this and they're moving and their whole face looks miserable, those are the patients with frozen shoulder. Key points with frozen shoulder: there's no real trauma. They have pain all the time. Their range of motion is limited. Classically, we say it's external rotation that's limited. What I find is most limited is if you bring their arm up like this, they cannot internally rotate, so they become a teapot. So you can kind of tilt them down or their shoulder blade moves. Sometimes they can maintain some external rotation, but the thing that really disappears first is that internal rotation, which is why they can't reach up their back. We don't know why frozen shoulder happens. It's kind of a fascinating disease. There's no such thing as frozen hip, frozen knee. There's no frozen ankle. There's no frozen fingers. We think it's associated with something that ramps up your immune system. So we saw a ton of it after COVID. Seems to be associated with diabetes, a pre-diabetic condition. But the bottom line is those are all things that we say when we don't know what the exact etiology of it is. The natural history is misery, and then happiness, but over the period of somewhere between 2 to 3 years. What it actually looks like, if you were to put a camera in, makes a lot of sense. If I said it's what would an inflamed shoulder look like if I could take a picture, this is what it looks like. So on the left are arthroscopic images. Everything's hyperemic, it's inflamed. If you look at the capsule, it's got a ton of scar tissue in it. And the way I like to think about it is you get this inflammatory cascade in your shoulder. Inflammation stimulates your body to form scar tissue. Once you get that scar tissue, your capsule contracts a little bit. But every time you pull against that tighter capsule, it just sees that as a little mini insult, and then it hurts a little bit more, and then over time you lose more and more range of motion. Because we never raise our arms above our shoulders, less than 0.0001% of the time, even when we raise our hands, we only go to 90 degrees. Patients will progress pretty far along before they're actually seeking treatment for this. So your treatment options are benign neglect. Everyone gets better, which is kind of crazy and awesome. You can do physical therapy. How many of you are physical therapists? How many of you like seeing really stiff frozen shoulder? Yeah, don't do it. It's mean to the physical therapist, it's mean to the patients, and it doesn't actually really work all that well until they're already fine. Injections and anti-inflammatories are kind of the mainstay for this, and we almost never operate on frozen shoulder. So there are a couple of studies that show how important this is. Living with frozen shoulder makes you about as miserable as cancer. So it sucks. So when patients come in, don't say it's just frozen shoulder, you'll be fine. You can say you'll be fine eventually, but I hear you, this sucks. when they look at what happens, so in England they have this amazing thing called the National Healthcare System, or NHS, where you don't get treatment for a long time. So they did this study where like, welcome to the NHS, you have frozen shoulder, we'll see you in 2 years. Everybody got better. Almost everybody returned to function or near full function. The average duration of symptoms is 1.6 years. So I tell patients, good news, no matter what we do, you're gonna get better. Bad news is if we do nothing, it's going to take a year and a half, maybe 2 years. And patients are like, this is America. They don't like that. So I say, okay, so let's talk about things that can make you better. Injections into the shoulder joints, and I pretty strongly believe that these should be done under ultrasound, so that we know that the injection gets into the joint, does make people feel better. Steroid, meaning anti-inflammatories, gets patients better faster than placebo. Doing a suprascapular nerve block. So if you have somebody like Dr. Berrigan that you can refer to, it helps get patients better, faster. I use this for my kind of miserable patients. They can't raise above 90, they can't sleep, they can't do their daily activities. That tends to work pretty well. And then there's some question about whether or not kind of pushing as much fluid into the shoulder to kind of dilate the capsule is beneficial. We used to do this in the OR. We would turn a pump on. Normally in shoulders, we want the pump pressure around 40. They would turn it up to 100 for about 5 minutes to just distend everything. It doesn't really show that it works all that much. This study I thought was interesting in that it's not the best study, but it did show that patients that got this was not blinded, but their psychological feelings got a lot better. They weren't as sad, they weren't as anxious about their shoulder. So there is something about reversing it. And I think whatever works for patients, bottom line is anti-inflammatories. Physical therapy, it works, but it works after the patients are already getting better. So don't send patients on the descending part of it, send them on the improving part of it. I tend to tell my patients, like, let's do the injection first, wait 4 to 6 weeks, and then start physical therapy. I never do surgery for adhesive capsulitis unless they failed for a year, they're brittle diabetic. I haven't done one in the last 2 years. There's nothing new in frozen shoulder. Don't do stem cells. It's not an alternative to shoulder surgery. There's no PubMed data on stem cell therapies. There's no real data on PRP. This is a single case series. You would think PRP is an anti-inflammatory. Hasn't really been shown to be beneficial for frozen shoulder. I don't recommend it. Save your money, do a $5 steroid injection. If you want to read more about uncurable processes, this was a really, really nice paper. Dr. Millar and Dr. Rodi have written a couple of these in Nature reviews, but it kind of tells you everything about it in the language that is both like, I know all the basic science, but also I can explain this to patients. It's really well done. Okay, so when patients come in with loss of passive range of motion, I get x-rays. I want to make sure they don't have the arthritis. Once they have their arthritis, it's a different treatment pathway. If they have no arthritis on x-rays and they have a limited range of motion, this is frozen shoulder no matter what they tell you, no matter what that MRI shows, this is frozen shoulder. For less than 3 months, and they really have full range of motion except for a little bit of rotational defects and a lot of pain, I will send those patients to physical therapy, but those are the exception, not the rule. For more than 3 months, and they're limited in what they're doing, they can't reach their belt, I will do an injection first, and as they start to get better, I'll do physical therapy. Okay, what patients really want to know, for the love of God, will it get better? Yes. It will get better. It just takes time. You do not need surgery for this, no matter what the MRI report shows. And you won't do any damage. It might feel miserable when you move your shoulder, but you're probably maintaining some range of motion. So go ahead and do your activities, but it will hurt, so take anti-inflammatories. Okay, so 67-year-old woman presents with 4 months of shoulder pain, occurred after taking her jacket off. Pain is mostly in the back of the shoulder, sometimes in the front. She has trouble getting things off high shelves, can't put her belt in it. Shit, this sounds the same as last one. MRI shows a posterior labral tear and some other stuff she didn't remember. She didn't bring the report, she didn't bring the imaging. What does she have? Frozen, oh, I wouldn't do 2 in a row. I could. That'd be really mean though. That'd be really mean. What else could she have? Arthritis. Yeah, so you're thinking arthritis, rotator cuff tear, frozen shoulder. Thank goodness, we have x-rays. So the wonderful thing about x-rays is once you get an x-ray, it tells you in one word, usually 2 words, one the patient will panic about. You don't need any more imaging. You don't need anything else. It'll say severe degenerative glenohumeral arthritis, narrowing of the joint space. What it doesn't say is partial thickness rotator cuff tear, posterior labral tear, because once you get the MRI, buried way down at the bottom of the report, it says bone-on-bone articulation. Please, 35% of the patients that come in to see me with arthritis have already gotten an MRI, and they really want that labral tear fixed. And I have to break it to them. It's not the labral tear. It's the fact that that labrum has been torn for 30 years, and your x-ray looks like you have really clinically significant arthritis. So an x-ray is incredibly diagnostic in this case, because it's either going to rule in or rule out either frozen shoulder or shoulder arthritis. So again, this is the top part of this. Shoulders, if they have x-rays and they have arthritis, they have considerable pain, limited activities of daily living. I will say we can do surgery. I will also offer, if they're not ready for surgery, we can do physical therapy. Physical therapy doesn't work in the sense that it makes the arthritis go away. It doesn't work in the sense that you will get clinically meaningful differences in terms of your range of motion or strength. But if you want to do physical therapy, you will be happy that you did it. And you're like, how does that work? It's because you can be happy that you did something even if you don't actually feel better. That's fine. Like patients like, I want to do something. And I did physical therapy. I'm like, can you raise your arm up anymore? No. Are you happy with how you're doing? Yeah, I'm doing great. I love my physical therapist. So thank you to the physical therapist. You make the patients happy without making them better. It's also called being a spine surgeon. So I know, too easy. You can also do an injection, and an injection of steroid into the glenohumeral joint is a good temporizing measure. Surgery works for this, and we'll talk a little bit about it, but not too much. Again, we just talked about this. We just did a study that we published 2 years ago. PT doesn't work, but patients were happy, especially when you see bone touching bone. There's nothing that untouches the bone. So surgical treatment for arthritis, patients want to know what it's like. It's outpatient to 1 to 2 night stay. You wear a sling for about 6 weeks. 90% of patients do well. The overall complication rate is about 2%. The problem is, as with any joint replacement, once you are that 1 to 2%, it's an unmitigated disaster. So I tell patients, hey, look, 1%, really, really low, right? But if you have that complication, it's a big deal. So you always want to be going in for checkups, especially if you think something's wrong. Things that are new and that make our job better is we can do more patient-specific implants. So now that those patients that we used to say these are too complicated, we can actually design implants for. So I just did a 90-year-old. He's super old. He's super tiny and frail. He's got a lot of bone loss. For only $1,000 more, we're able to design an implant that fits right on his bony socket. Means the surgery's faster. It only took us about 70 minutes. This used to take probably 2.5 hours. So we can get an older patient in and out of the OR safely and back to doing the things that he wants to do. What patients want to know about shoulder arthritis, will you get better? Yeah, but it's kind of a deteriorative process. Like you can get better in the short term. If you think about what arthritis looks like for patients, we say it's a waxing and waning course. It never goes away. You don't need surgery right away. You can wait 1 to 2 years. Will you damage the shoulder? No. If you have arthritis, the horse left the barn, it's a genetic problem, most likely. You're going to do a lot better if you do surgery at some point, but you're not making it worse by using your shoulder in the meantime. Okay, last thing, 39-year-old computer engineer, 4 months of anterior shoulder pain, bro. Doesn't complete his workouts. He had an MRI, it shows a slap tear, but he's got a triathlon coming up and he's got to do it. So is there acute injury? No, it seems like it gets worse at the gym. Hurts in the front of the shoulder. These patients can narrow down exactly where their pain is. They're not really losing any range of motion. And no, dude, I'm not losing strength. I still went to the gym this morning. Come on. So biceps is a really, really poorly designed complex. How many different tendons go through a joint, make a right angle turn, and then attach to a flimsy structure? Like none. It is horribly designed. Why do we have them? Because we used to walk on all fours. Like if I had to redesign humans, the things I would change, I wouldn't eat where I breathe. You'd never need to worry about choking. You'd just have gills. And I wouldn't have a biceps tendon. So whether or not it's a biceps tear or a slap tear, for the vast, vast majority of patients, it doesn't matter. Our treatments are going to be the same. So a slap tear tends to be more of a throwing and acute injury. You're going to have pain with O'Brien's. The pain is kind of deep and posterior. O'Brien's test is when you come over like this. But there's really no pain in the bicipital groove. Biceps tends to be overhead, activity-related. They'll still be positive with O'Brien's test. It's still the same structure. They have tenderness in the groove that's reproducible. Treatment for slap tears, younger than 35, physical therapy. You can consider surgery for either a slap repair or biceps tenodesis. Older than 35, any superior labral tear is probably a normal finding. Don't panic. Don't let your patient panic. This is more clinical diagnosis. I will non-op almost everybody. Whether or not they need physical therapy depends on if you ask me or Danny. A lot of it's just posture. Avoid the offending activity. Drew and I did this study several years ago now, but basically normal findings on your imaging, anything to do with the labrum over the age of 50. So don't panic when they have a superior labral tear over the age of 50. It's a normal finding. I'm going to stop with this. So this is my algorithm. They have a true superior labral tear. It's truly an acute injury. We'll try physical therapy. I'm often surprised in how patients do with this. And if slap repair, my cutoff now actually is probably around 25. People really like having a biceps tenodesis. For biceps tendonitis, PT, range of motion, almost everybody's going to return. The patients that really have persistent pain in the front of the shoulder, have them get an ultrasound-guided injection. And then most of those patients will get better. If all else fails, I'll do a biceps tenodesis, which is a relatively easy surgery. It's a very easy surgery to do, pretty easy surgery to recover from, and has really, really good outcomes, 95% success rate. Okay. What patients really want to know, and then I promise I will stop. Will you get better? Yeah, it's just biceps tendonitis. Probably if you just change how you do your push-ups, you'll probably be fine. Sometimes we can do an injection. Almost nobody needs surgery with this. They're going to get better on their own. And you're not going to damage it more. Patients, once they hear they have biceps tendonitis, the next thing they think is it's going to rupture. I've seen 2 patients in my life that have ruptured with just pure biceps tendonitis. And then you can still fix it, but also then your biceps sags a little bit and looks better in a shirt, bro, so you're good. All right. So physical exam. Okay. How many minutes do I have? Like 3? All right. I'm going to bring Alex Jr. We have 2 people in lab. Alex Sr., who's Sir Alex, and then Alex Jr. Alex has torn everything in the lower half of his body, so he's going to be careful coming up. Okay. All right. So how do you do an exam in under 3 minutes? And if you think about what exam things you want to know, like there's about 100 shoulder maneuvers, none of which you actually need to know. Because what you want to know is it something that's going to get better on its own? Do I need to send them to physical therapy, or do I need to get more imaging? So what I do is I say, show me what you can do. Can you get your arms all the way above your head? Usually I have them face me, but sure, okay. He's like this in lab too. It's a lot. All right, face me. All right, bring your arms all the way up. Good. Come down kind of medium speed. Good. So painful arc test. Patients with a rotator cuff problem, you don't know the size, can't do this. So they'll do all sorts of weird things. They'll kind of bring their arm up, down like this, or they'll be like, I can get all the way up and come all the way down, okay? That's a rotator cuff problem. But I just ruled out arthritis, frozen shoulder, and a rotator cuff problem, okay? So I'm kind of done. Patients come in like it really hurts, but I'm good. You're like, okay, good. This isn't too bad. Okay, so rotate out like this. So external rotation tells me, is their infraspinatus intact? So sometimes they can't really raise their arm up like this, but they can still do this. So that's kind of a medium-sized rotator cuff tear. Or they're stiff coming up like this. They're stiff like this. I'm like, okay, I probably need an x-ray. Is this frozen shoulder? Is this arthritis? Okay, how much can you reach up the back? Good. So now I've tested all of range of motion. If they're limited, so let's say Alex can't raise his arm up like this. I'm like, okay, frozen shoulder, he's stuck. If I can get him all the way up, it's a cuff tear. Okay, so I know like that was less than a minute with me talking. I already have diagnosed those things. Okay, the next thing I want to do is test strength. Arms up like this. Don't let me push down. So this tells me multiple things. It tells me, and usually what I'll say is, does this feel different than the other side? Because pain is relative. Patrick Swayze says pain don't hurt, so I agree. This is Job's test. So arms like this, it doesn't matter, thumbs up or thumbs down, but push down if he says, yeah, this hurts here, or he feels weak, or he's doing all these weird things to hold his arm up. That makes me think rotator cuff problem. Arms down like this, hold your elbows at your side, go all the way out again, keep your arm there. So when I push in, you have to have a pretty big tear if you can't do this, okay? Then the last thing I do is I want to test their subscap, the rotator cuff in the front. So I have them put this arm down, take this hand, put it over there. Don't let me lift off. And somebody with a subscap tear just kind of lifts right off. Lift right off. There, well, not that much. So they'll kind of lift off like that. So they'll kind of try to keep their fingers on. And then the last thing I do is I just kind of push on them. Okay, so I'll push on their SC joint. It never hurts. Kind of work my way over all these things that don't hurt for them. Push on their AC joint, which almost never actually hurts. And then I'll find their biceps tendon. And their biceps tendon sits kind of in this groove that you can feel because there's kind of a raphe in the deltoid. It's not actually under the skin, but what patients with biceps tendonitis will say is, yep, that's where my pain is. And you're like, great. What if I move it out of the way and press the same spot on the skin? And then they're like, yeah, it's gone. I'm like, great, okay. It's there, it's gone. So you can confirm it just by the location. If you think the reason why is because your biceps is sitting in that groove and you're either exposing it to your finger or hiding it away from your finger and just pushing on basically greater tuberosity. Cuff tears don't hurt if you press on it. Frozen shoulder actually doesn't usually hurt when you push on it. These patients are miserable, but then you push on them, they're like, yeah, that actually doesn't hurt. Arthritis sometimes will have a little bit of pain in the back of the shoulder, but that's pretty nonspecific. And that's really at this point all I do. I rarely do Neer's test because I think Job's does most of the same thing. I will sometimes do Hawkins test, but I find it really nonspecific. O'Brien's I'll do only for superior labral tears. And dislocation and instability is a different exam that I'm not going to be doing in a 55-year-old. Okay? All right. Thank you. Bye. Questions?
Wow, they really don't want to ask you questions.
I know.
Don't blame you guys.
Yeah, I don't blame you. Yeah.
All right, we'll
Sorry. No, two.
Here, we'll go here.
What do you think about using ultrasound versus MRI to take a look at rotator cuff tears?
So that's a great question. So I think if you're getting advanced imaging and it's guiding your management, I think getting an MRI is better. And the reason is you should be getting an MRI when they failed the first line of treatment, which would be rest, anti-inflammatories, and physical therapy, and you're thinking, does this patient need more advanced surgery? Well, if you get an ultrasound, we don't see structure very well. It'll give us a yes, no, there's a cuff tear, versus an MRI tells us structure, size of tear, quality of muscle a lot better. So I prefer MRI. It does make them happy, and so what I would say is for that patient is like, I really need imaging, and you don't think that they have a tear and they just need reassurance, ultrasound is fantastic. But if you're thinking this patient needs surgery, they're going to get an ultrasound, and I'm going to send them for an MRI. Yes?
You know, there's all sorts of surgery, I know, but I was told if I had surgery on my shoulder, it would take me 6 months to be able to use my shoulder, and I want to work, so I don't want a surgery.
Yeah.
How long does it take to rehab the shoulder?
A year.
A year. So,
Yeah.
It's like,
it's horrible. Yeah, it's because the physical therapists are really slow and bad at their job. Yeah. Thanks, Danny. No, so it's absolutely right. So the problem with a lot of our surgeries is it isn't like having your appendix out. There's the surgery, there's the insult of surgery, there's the time that it takes to repair, and then it takes the time to recover from the surgery and the sling wear and the muscle atrophy. So for patients, what I tell patients is 6 weeks in a sling. For any repair, that's almost non-negotiable. The next 6 weeks, range of motion. During that time, you can go for a run, you can go for a hike, you can work unless you're a hardcore manual laborer. Another 3 months of strengthening. At 6 months, I will let you go back to doing the things that you want to do, but it will be a year until you've maxed out. So the pessimist way is like, no way am I going to do that. The optimist way is like, look, I got a year to get better. Like any given day isn't the end of the world if I'm not feeling better. But yeah, it is they are totally right. It takes a long time.
I think you said during the osteoarthritic portion of your talk about genetics having an influence on it.
Yeah.
Would you say that cartilage loss in the whole body can be genetically influenced?
Cartilage loss in the whole body is genetically influenced. Yes, 100%. So you can think of arthritis as a whole body problem. There's one of my colleagues, Kelsey Collins, just put a review out in Nature Reviews Rheumatology. It came out yesterday. It's really, really good. It's a whole body problem. Why some joints are affected more than others, we don't know. But when you think about arthritis, the way I tell patients, probably 2/3 genetics, so blame your parents, and 1/3 environmental exposures. The problem with environmental exposure, that can be trauma, that can be diet, that can be exposure to things that we don't understand, but it changes the makeup of the DNA, not only in the cartilage, but also in the underlying bone and the bone marrow underneath it. And what we think is that those combination of hereditary plus genetic mutations is what predisposes people to it. Ask me that question next year, I'll have much better data and weird graphs to show.
So a few times you said first step for a lot of these is like NSAIDs, rest, and just kind of giving it time so it gets better. What are you saying more specifically to them with the rest portion? How long is it kind of wait for you to start doing?
Yeah.
Like no over the head activities? Is there any utility of sling? Would it cause any problems if?
Yeah, so never sling. Never sling unless they have something that's actually physically broken, especially if they have inflammation, they're just going to get stiff. I usually tell patients, it kind of depends on age. So if they're really, really young, like under 30, I say, 4 weeks of rest. And if you think about Olympians after the Olympics, they will not exercise for about a month. For people in their 40s to 60s, that's closer to 2 months of resting the offending body part. So that means for a shoulder, you have like a lot of inflammation from impingement and you really, really, really like riding a bike, you're not riding a bike for 2 months. So go find something else to do core work, do other things, but let your body rest. And oftentimes that's why patients really like doing physical therapy because it makes them feel like they're doing something in between. And then NSAIDs pretty much all the time because they work. And if you ask patients, one of the questions I often ask is, did the anti-inflammatory that you took last week work? And they're like, yeah. I'm like, how much did it work? Oh, yeah, I had no pain. I'm like, oh, how about we try that for 2 weeks and see how you do? And then patients don't come back. So either they all hate me or anti-inflammatories really work pretty darn well. Don't answer that, Danny.
So tempting. Let's go to the after one. You said that multiple steroid injections might be worse for the patient, but does it matter how much time in between those multiple injections?
Yeah, it's a great question. We don't have data on that. And the problem is the studies have been done in a few different models. We look at human models, meaning we look at how the studies have been done and the data's kind of all over the map. We know 5 or more within 2 years of surgery has a slight re-tear rate for rotator cuff repairs. We know in a dish, if we mix corticosteroids and cells, doesn't matter the cells, it doesn't actually do anything, but if we mix corticosteroids and a anesthetic like lidocaine that's very acidic, that will kill a bunch of cells. Not the corticosteroid, the acidic lidocaine. So that's why we tend to use different ones like Marcaine or bupivacaine or ropivacaine. In terms of time in between, I usually tell patients, look, don't come back within 3 months. If we're doing something every 2 months, it's not really making that much of a difference.
I'm going to combine these two questions into one. So, do you tell patients with other shoulder conditions to keep up range of motion to prevent frozen shoulder? I learned this in the past, I'm not sure if it's accurate. And do you have recommendations for preventing frozen shoulder?
Ooh. Okay, so prevention, no, don't ever get sick because we think as soon as you increase your, so get your flu shots, really no, we don't know enough about it for me to give good information on how to prevent it. And yeah, I tell patients to maintain range of motion, especially through minor injuries. So like if, let's say you have a non-displaced greater tuberosity fracture, something that's gonna heal on its own, I'll say sling for 2 weeks, no active range of motion for another 4, but come out of the sling and start doing pendulums relatively early. So you don't want that post-traumatic frozen shoulder.
Do you send nerve blocks and steroid shots? I've never done nerve blocks, only severe cases of frozen shoulder pain or if they fail steroid shot after 4 weeks.
Do I send them?
That's what, do you send them for nerve blocks?
Yeah, so I ultimately, so we're really lucky and we have a great primary care sports group, so it's unfair. So what I do is I say, oh my God, I'm so sorry you have frozen shoulder. Good news is you don't need me. I'm gonna have you see Dr. Hadamir, Dr. Berrigan, or Dr. Center, and they're gonna figure out what to do. But I think, honestly, more is better for a lot of the patients, and even if it's somewhat psychological, knowing that they got the nerve block plus a big dose of steroid, they feel like they're getting like, you know, the full court press and they feel better about it. So I think that's oftentimes the way you guide treatment. And other patients are like, I'm just gonna see how I do. Like, I don't want an injection. I can manage with this, just knowing that this isn't something that's gonna get worse and is permanent.
What are the circumstances where you'd want a patient sent to you with an arthrogram instead of an MRI?
Like a CT arthrogram or an MR arthrogram? Either. So CT arthrogram if they have a pacemaker and can't get an MRI, but a lot of pacers are MRI compatible. Almost never do we need an arthrogram at this point. I think MRI quality has gotten better, our ability to look at them is better. If you're dealing with like a really, really low magnet MRI, which most places aren't anymore, then we don't really need an arthrogram. The only place I really still like arthrograms isn't even in the shoulder, but for possible recurrent meniscus tears, and you're deciding surgery or no surgery.
Topical NSAID for impingement.
Have you ever put a topical NSAID on your body?
I have not.
Yeah, try it.
Okay.
Yeah, you smell good. You smell like a 70-year-old man. So it smells like the start of beta breakers, but other than that, yeah, I don't think it actually works. Maybe AC joint, maybe pes bursitis for impingement. No, like your deltoid is this thick. Even in skinny people, it's that thick. I don't know how it would go. Now some patients will ask for it. I'm like, absolutely, let's do it. Let's rub you all up, but not in the clinic, please.
All right, on that note,
Yeah.
time's up. Thank you, Brian, for a great talk.